The next topic of discussion is the double-peaked pulse, specifically meaning pulses that inherently possess two distinct peaks. These are divided into two main groups. When both peaks occur during systole, for example, in patients with aortic stenosis, aortic insufficiency, and those with hypertrophic cardiomyopathy. The second group are those in which one peak occurs in systole and the second peak in diastole, such as dicrotic pulse and intra-aortic balloon pump. There is a third group that are not considered double peak pulses. But in these cases, the arterial pulses alternate in strength, becoming stronger and weaker one after another, and two conditions can lead to a Bisferiens pulse. One is bigamy due to PVCs, and the second is pulsus alternans. In a patient with aortic stenosis, due to the narrowing of the aortic valve, blood exits the valve with more difficulty, and it also takes longer for this volume of blood to pass through the aortic valve. For this reason, both the amplitude of the arterial pulse decreases and the peak of the arterial pulse occurs with a delay. That's why the arterial pulse in a patient with aortic stenosis is called pulsus, parvus, et tardus. This is a normal arterial pulse. As you can see, we have a rapid upstroke. That is, the ascending limb or anacrotic limb has a very steep slope and reaches the peak very quickly. But in a person with aortic stenosis, the ascending limb has a gentler slope and reaches the peak with a delay. And on the other hand, the overall amplitude of the pulse is also reduced compared to a normal pulse. Therefore, a patient with aortic stenosis has three characteristics, which are as follows. It is slow rising, late peaking, which we call pulsus tardus. Tardus means delayed, and low amplitude means its height is reduced, which we call pulsus parvus. The combination of these is called pulsus parvus et tardus, which is a specific characteristic of aortic stenosis. And as we mentioned, in a patient with aortic stenosis, we have two peaks during systole, with the second peak being higher than the first. This specific feature of aortic stenosis is called an anacrotic pulse. In a patient with aortic stenosis, the left ventricular outflow tract is narrowed, and it takes more effort and a longer period of time for the blood to exit the left ventricle. It's like when you're watering the garden with a hose and you put your finger in front of the water outlet. This causes less water to come out of the hose, and it takes a longer time. There are some diseases that don't have the classic characteristic of pulsus parvus et tardus, which is specific to aortic stenosis, but they do have part of it. For example, patients with heart failure have pulsus parvus, meaning the height of the arterial wave is reduced, or patients with left bundle branch block have pulsus tardus. The second disease that leads to the creation of two peaks during systole is aortic insufficiency or aortic regurgitation. In a patient with aortic regurgitation, during systole, a large volume of blood exits through the aortic valve and enters the aorta. And due to the effect it creates, which we call the Venturi effect, it leads to the formation of a double peak during systole. Another characteristic of aortic insufficiency is rapid rise and rapid fall, meaning it goes up very quickly and also drops very quickly. And on the other hand, because cardiac output has increased, systolic blood pressure rises, and due to diastolic runoff, diastolic pressure decreases. Therefore, the third characteristic of patients with aortic regurgitation is a wide pulse pressure. For this reason, the arterial pulse in patients with aortic regurgitation will be very strong and full. This strong pulse is called a bounding pulse. If we feel this bounding pulse in the carotid artery, it's called Corrigan's pulse. And if we check it in the peripheral arteries, it's called a water hammer pulse. And the two systolic peaks in a patient with aortic insufficiency are usually of equal size. The next condition that leads to the appearance of two peaks or crests during systole in the arterial pulse is HOCM. Hypertrophic obstructive cardiomyopathy. In these patients, there is an obstruction in the left ventricular outflow, but this obstruction is dynamic, meaning there is no fixed obstruction. Unlike aortic stenosis, in these patients, due to muscular hypertrophy below the aortic valve, blood is easily ejected at the beginning of systole. However, the more the left ventricle contracts, the hypertrophied muscles make the left ventricular outflow tract, or LVOT, narrower. As a result, blood is ejected more slowly, and the arterial waveform that this creates is called the spike and dome pattern. Spike refers to a spear-like shape, and dome refers to a dome-like shape, where the first part, the spike, has a higher peak than the second part, which is the dome. We specifically see this pattern in patients who have HOCM. If you found this video helpful so far, please like it and share it with your friends. And if you don't want to miss my future videos, please subscribe. The second group of patients who develop a double-peaked pulse or double-peak pulse are those who have one peak in diastole and one peak in systole. This is seen in two groups of patients. First, those who have a dicrotic pulse, and second, those who have an intra-aortic balloon pump. In patients with a dicrotic pulse, the cause is due to increased peripheral vascular resistance. That is, vascular resistance has increased. In which patients does peripheral vascular resistance increase? In patients with hypovolemia, cardiogenic shock, septic shock, or hypovolemic shock. For this reason, the reflected wave increases in amplitude, and this leads to the presence of a double peak. So in these patients, because they are in shock, the overall height of the arterial pulse decreases, the dicrotic notch becomes more prominent, and as a result, the dicrotic wave increases in amplitude. Their arterial waveform resembles the letter M in English, which is called an M-shaped pulse, and the height of the first wave is greater than the second. That is to say, the initial prominent peak is noticeably higher than the subsequent second peak, indicating a significant difference. The second situation that causes a double-peaked pulse, meaning an arterial pulse with two peaks, one during systole and one during diastole. These are patients who have an intra-aortic balloon pump. What is an intra-aortic balloon pump? In patients who have low blood pressure or are in shock, we use a balloon pump. As the name suggests, it's a thick balloon that we insert through the femoral artery and place inside the aorta. Basically, this balloon is positioned between the left subclavian and the renal artery. Now, how does this balloon work? During systole, this balloon is completely deflated. That's why when the left ventricle contracts, it sends blood forward, and without any resistance, the blood not only reaches the carotid arteries, the head and neck vessels, and the coronary arteries, but also easily reaches the vessels of the lower limbs. But during diastole, when the aortic valve is closed and we have a drop in blood pressure, this balloon inflates. When this balloon inflates, it prevents blood from reaching the lower limbs during diastole, and blood flow is directed only to the vessels that branch off from the aortic arch and proximal aorta, meaning the coronary arteries and carotid arteries. And what is the purpose of the balloon pump? To maintain blood supply to the vital organs, which in our case are the heart and brain. Therefore, the purpose of the balloon pump is to inflate during diastole and keep the blood in the aortic arch and descending aorta, ensuring perfusion is preserved only for the vital organs, namely the heart and brain. However, blood supply to the distal organs and lower limbs becomes impaired. Now, what effect does this balloon pump have on the arterial pulse? As we mentioned, during systole, it remains unchanged. Therefore, the initial part, which corresponds to the percussion wave or the systolic peak, remains unchanged. But during diastole, that is from the point where we have the dicrotic notch and the aortic valve closes, the balloon inflates. As a result, the diastolic wave segment rises sharply in height, and this diastolic wave height will even exceed that of the first peak. This is characteristic of the arterial pulse in a patient with an intra-aortic balloon pump. There are two peaks, one in systole and one in diastole, and the height of the second wave, which is in diastole, is greater than the first wave. There are some conditions where the arterial pulse does not have two peaks, but the arterial pulses alternate in strength, becoming stronger and weaker every other beat. One example is patients who have bigeminal PVCs. When a PVC occurs, because it is a premature beat, during diastole, the left ventricle does not have enough time to fill with blood adequately. Because of this, since the blood volume decreases, the stroke volume also decreases. And as the stroke volume drops, the blood pressure falls as well. As we mentioned, blood pressure equals cardiac output multiplied by resistance. That's why following a PVC, the height of the arterial wave decreases. The arterial wave resulting from a normal QRS is completely normal with a normal height, but the arterial wave resulting from a PVC has a reduced height. And we will consistently observe this distinctive pattern alternating every other beat. Therefore, the presence of bigemini PVCs invariably leads to the formation of a characteristic bigeminal pulse. The second cause of a bigeminal pulse is a condition called pulsus alternans, where the arterial pulses alternate in strength, becoming weaker and stronger every other beat. When we look at the ECG, we see that it is completely normal, meaning there are no PVCs. The QRS intervals are also consistent, but when we observe the arterial pulse, we see that one beat has a normal amplitude and the next beat has a reduced amplitude. Pulsus alternans is seen in patients with heart failure and advanced left ventricular dysfunction. The main cause is unknown, but it is said to be due to a disturbance in calcium metabolism. The Frank-Starling law plays a role here. When one beat is weak, it causes a larger volume of blood to enter the LV on the next beat, so the stroke volume increases and the following beat becomes stronger, and this alternates with each beat. What is the difference between pulsus alternans and PVC bigemini? In PVC bigemini, our ECG shows PVCs every other beat. Whereas in a patient with pulsus alternans, the QRS complexes and ECG are normal and there are no PVCs. But in both of these conditions, the arterial pulse alternates in strength every other beat. The second difference in a patient with pulsus alternans is that the interval between pulses is constant, meaning the atrial pulse repeats at regular intervals. But in a patient with bigemini PVCs, not only do they have PVCs every other beat on the ECG, but the intervals between arterial pulses are also variable. That is, the PVC pulse occurs at a shorter interval after the normal pulse. Therefore, in a patient with pulsus alternans, the arterial pulse is regular and the arterial pulse repeats at regular intervals. But in a patient with bigemini PVCs, the arterial pulse feels irregular. There is another term called electrical alternans. This means that in the patient's ECG, the QRS complexes alternate between being large and small. The reason for this is the presence of pericardial effusion or tamponade. Because the heart is surrounded by fluid, it is essentially floating in the pericardial fluid. That's why when the heart moves closer to the chest wall, the QRS complex recorded by the device appears taller, and when it moves away, the QRS amplitude becomes smaller. Therefore, the QRS complexes alternate between being tall and short, and unlike pulsus bigeminus and pulsus alternans, where we said the arterial pulse also alternates in strength, in this case, the arterial pulse remains completely stable and the atrial pulse does not change. Only the ECG shows alternating QRS amplitudes.